Currently we have several immunotherapies approved. Regarding these approved immunotherapies, we have elotuzumab as an antibody that targets SLAMF7 present on the myeloma cell surface, and we have approved CD38, the CD38 targeting antibody daratumumab, a single agent but also in diverse combinations, such as the combination with Lendex, with Velcade dexamethasone, and in the US we have also approved the combination with Pondex and MPV. My talk was about how to prevent resistance to monoclonal antibodies, and then I think it's important to realize that when you combine an antibody with other approved myeloma agents, the depth of response is much deeper, the time that the patient has the response is much longer. So I think combination is critical to prevent development of resistance towards antibody-based therapies, and in the future I think we can improve upon this by getting a better understanding of mechanisms of resistance, mechanisms of action of elotuzumab and daratumumab. So in my talk I discussed mechanisms of resistance in terms of resistance to ADCC, CDC, ADCP of daratumumab, and how a better insight has already gained a lot of information, and now currently several trials are enrolling patients to see whether this insight is really making antibody treatment more effective. So I discussed that CD38 expression is a determinant of response. However, there's a big overlap between responding and non-responding patients in terms of CD38 expression, so it's not a perfect predictor of response, so we cannot use CD38 to see whether we will treat or won't treat a patient with daratumumab, but it's a determinant of response. And at the same time we found that CD38 goes down during treatment. So maybe new drugs that increase CD38 expression on the myeloma cell may be beneficial and make a difference for the patient. I also discussed that NK cells go down during treatment, and this may impair ADCC activity of daratumumab, and maybe we can give the patient ex vivo expanded NK cells, which are pre-treated with fat fragments of daratumumab in order to block CD38 and in order to prevent the depletion of these cells. But we have to see in trials whether this works or not. And then I discussed that also the upregulation of complement inhibitors confers resistance to DARA, and maybe we can also in the future block CD59, CD55 to enhance CDC and thereby improve antibody-based outcome. And then in the end of my story I discussed that when the patient is truly resistant to antibodies, one option is to change the accompanying drug, so change from a DARA-IMiD combination to a DARA-PI combination, but we need more information from clinical studies about this type of intervention. And another option of how to treat patients with antibody resistance is to go to another drug with a completely different mode of action. And in this respect, selinexor and venetoclax are new kids on the block which are really working differently. Selinexor by inhibiting XPO1, which is involved in the nuclear export of tumor suppressors, and venetoclax is an important inhibitor of the BCL2 pathway. So these two can be also used in combination with other drugs, and these are also, I think, promising new drugs for DARA and ELO resistant patients. And also BCMA targeting agents are very promising in this respect. So now we also have BCMA targeting agents such as BCMA CAR T cells, BCMA antibody drug conjugates, and BCMA bispecifics. And I think these BCMA targeting drugs are also very promising, and hopefully we can use them also outside of the clinical trial setting in the nearby future.